Thanks for bearing with us and staying till the end as we talk about this important topic, which I think has underscored a lot of the different panels in terms of some of the data behind and also disparate outcomes in some of our patient populations. And I'm just happy to learn from my colleagues here who all represent very different institutions and styles of practice. And hopefully we can learn together and get some takeaways to bring back to clinic tomorrow. So this is a familiar situation. This is actually the similar case to what we discussed yesterday in our ER positive case. So we have a 45-year-old premenopausal Black woman who presents with a newly diagnosed breast cancer. It's invasive ductal carcinoma grade 2, ER/PR positive, HER2 1+, Ki67 is 15%, and the mass is 2.9 centimeters on imaging. Her axilla shows no abnormal lymph nodes. She does have a family history with a sister with breast cancer in her 50s, and her germline genetic testing is negative. So in terms of management, seems pretty straightforward. She undergoes her lumpectomy and sentinel node, and finally we get 3.2 centimeters of invasive grade 1 disease with negative margins at resection. 1 of 3 sentinel nodes are positive with 3 millimeters of disease, and the patient ultimately will undergo adjuvant radiation and also anti-endocrine therapy. So what would we expect her outcome to be? And I'll talk to Dr. Sonia to lead us through some of this.
Yeah, I think, we have seen, before I jump into this slide, I think we have seen overall that Black patients have worse outcomes across our different trials. We saw that with TAILOR-X, and now we saw that presented now recently at San Antonio in December, where we saw patients enrolled on our Exponder clinical trial, which we discussed yesterday, which focused on, of course, our node-positive patients that had a recurrence score less than 25. And what we saw when they did this analysis looking at clinical outcomes by race, non-Hispanic Black patients had worse outcomes independent of recurrence score. And I think this really makes us pause and try to answer this question, why? What are some of these factors that are driving these disparate outcomes in among our Black patients with breast cancer? And of course, it's not a simple answer, it's quite complex, and we know that when we think about social determinants of health, we think about access to care, but genomics, of course, plays a part in that, and I think it's something that we really need to start doubling down on our efforts to try to parse that through. As it pertains specifically to our Exponder and clinical trials on a whole, when we think about clinical trials, big picture, we always think that these patients are treated in a homogeneous fashion, right? So tend to receive similar treatment, of course. These patients, usually you would think you remove the access issue because these patients are being treated in a clinical trial. But then when you still see these racial disparities despite being treated in a clinical trial, it really makes you start wondering, are we missing some biological differences that we're not accounting for in our current, with our current assays? And if we want to go to the next one. Of course, we also looked in our Exponder, they stratified patients by menopausal status, and again, similar results were seen where despite both pre and post-menopausal patients, also Black patients also had worse outcomes with an invasive disease-free survival of 86.8% in our post-menopausal patients and 88.5%. I do want to make a comment, however, as we're kind of thinking about what was driving or what is driving some of these differences in outcome. When they looked at our Exponder and they adjusted for BMI, because of course they adjusted here for age, recurrence score, grade, etc. But when they added in BMI in this model, it decreased that difference but didn't disappear. So we know that BMI was definitely at least influencing some of that outcome. Black patients were more likely to have a higher BMI, but again, there still seems to be something more that we can look at, or some other factors that are contributing.
This is perfect. Any other comments down our panel? Neil, I know lifestyle work is your passion.
Yeah. So I agree with those comments fully. I think that, and I alluded to this a little bit yesterday, I think that the complexity of interacting factors is far greater than we understand, and we're only starting to understand that the complexity is greater than we understand. So I think that we've seen some data, particularly at San Antonio, which is really informative in that I think in this area we've been focused largely on social determinants, we've been focused on access, we've been focused maybe not as much as we need to be, but we have been looking at tumor biology and genomics. But we're also seeing emerging data that the tumor microenvironment, as well as host factors, as I mentioned yesterday, play a differential role in this population. I'll just give a quick example. At San Antonio, we saw data from the Montefiore group showing that the tumor microenvironment after neoadjuvant chemotherapy in patients with triple-negative breast cancer and ER-positive breast cancer who received neoadjuvant chemo is different by race. And in fact, when they did CD68 macrophage staining as well as CD31 endothelial staining, what you see is a difference in macrophage density as well as a difference in endothelial leakiness, if you will. And this has actually been validated as a tumor microenvironment metastatic score. And Black patients with residual disease had higher tumor microenvironment metastatic scores than non-Hispanic white patients. And this is one of the initial recognitions. There are other groups that have published similar work. I'll tout our own findings shamelessly. We've published that macrophage infiltration is higher, independent of BMI actually, in Black and Hispanic patients versus non-Hispanic white patients. So I think that these kind of curves that differentiate by self-reported race are actually biologically a lot more complex, and we're starting to get that data. This will help inform targeted approaches that perhaps race will inform, or we can develop a better risk stratification that includes social determinants, tumor determinants, microenvironment determinants, as well as host determinants.
Any other thoughts on the panel about these data?
I think the only thing I'd like to add to what Neil just said is, like, do you envision like a signature that would incorporate these and an actual risk tool that would go into?
I think that would be, yeah. I think that's the blue sky vision. You know, we have an instrument right now where all patients who come into MSK with a new diagnosis of non-metastatic breast cancer are essentially assessed, right, and many institutions have this, for social and familial factors. That's in place at a lot of places. If we can take that data and then merge it with the NGS data for those places that are doing it, or those patients that are doing it, and then the challenge will be, how do we then implement a microenvironment score? That perhaps is a little more challenging, but I think ultimately that would be the blue sky vision.
I think before we're able to come up with that microenvironment score, which I think would be fantastic, by the way, we need to get these patients on clinical trials. And I think that's really the infrastructure that we all have to work on, because regardless of what study you look at, we do not have adequate representation on clinical studies. And until we can get through that hurdle of allowing people access, but also convincing them of how important this is, I don't think we're going to be able to do the rest of the work that we need to do.
Absolutely, and that was the point I was just about to make, because when you look at our responder, only 6% Black patients were in our responder, right? And when you look at all other racial ethnic groups represented here, it was pretty close to the general population, right? We know for non-Hispanic Black patients, they account for approximately 13% of the US population, yet less than half of that was seen in the study. So I think we really have to be intentional if we're going to answer these questions that, again, we're still searching for these reasons as to why are we seeing these worse outcomes.
So I think these are very important discussion points, and let's delve deeper. So some facts that have already come up: Black women are about 40% more likely to die from their breast cancer compared to white women. And other factors that contribute to these disparities among racial groups include, well, they're multifactorial, which keeps coming up again in these discussions, but tumor biology, genetics, access to healthcare, medication adherence, and other social determinants of health. And we don't fully understand how genetics is influential in racial disparities and the survival, ultimately, of women with breast cancer. And again, kind of representation in research and clinical trials being critical in mitigating this. So just stating the problem a different way, although cancer incidence, and this goes across, not just breast cancer, we're at a breast meeting, but other, cancers as well as other medical problems in general, we know that mortality overall is declining in the US for our cancer populations, but there are certain groups that continue to be at increased risk for developing or dying of certain cancers. And these populations that may experience cancer disparities include groups that are defined by race and ethnicity, but I also want to challenge us to think about, disability, gender identity, also geographic locations. Dr. Jennifer's talked about, being in a more rural or disparate geographic location to reach a larger catchment area. There's also income inequalities that can underlie disparities, health literacy and educational barriers, age differences, which we'll talk about also in terms of clinical trial enrollment, and then as well as sexual orientation and national origin. So really there's a lot more to disparities than just black-white differences, and we really want to advance our interventions to be impactful on all of our patients. So, why is this happening, right? So this is a great kind of summary figure that I'm sure is familiar to a lot of us, looking at social determinants of health from the Kaiser Foundation, and it tries to break into different domains, what are some of the factors that may underline some of these social determinants of health. So we have things that underlie economic stability, so employment, income, debt, medical bills. We have neighborhood and even physical environment factors, so things like housing, safe transportation, walkability of a given area, as well as education, food, and then some of the more complex kind of community and social context factors, so social supports, discrimination, and even health coverage and provider availability, which we're used to thinking of. So we know that all of these complex domains in terms of social determinants of health actually interact along the health outcome spectrum, whether we're talking about surveillance, early diagnosis, treatment, and then even further down the line, ultimate outcome in terms of morbidity. So I guess I'll just start, down the line and see how our panelists, mind commenting on this, because, ultimately our goal is to figure out how can we as oncologists be more engaged in bringing more equitable cancer care to the communities that we serve. I don't know if...
Yeah, I think we have to be intentional, and I think we all are practicing in different areas and have that in different communities that have different needs. So I think you really have to look at where am I practicing and what are the needs and what are the gaps, and try to have a presence in that community. That way, if, for example, you have a high Hispanic patient group in your community, can we get into the advocacy groups, not just when you're trying to get them on your clinical trials, but having a presence. That way that community feels that there's some trust, there's some collaboration with that academic center, that community practice, where they see you as an ally, as a partner, not just someone that then wants you to be a part of a clinical trial. I think that kind of structure truly works when you're trying to build trust in these communities that have been excluded for such a long time in a lot of our trials.
Yeah, I agree, and I think my focus, and I can make some comments on the clinical trial design and scientific approach, because I think my colleagues have said some really important things about merging our practice with social determinants of health and access and so forth, but I think we can do better on clinical trial design and our scientific approach, because when we review grants or trial designs that are lumping disparate types of breast cancer together, we all say, well, we need to stratify or have separate cohorts. Well, we've just been saying that that breast cancer is biologically different in Black patients, in Hispanic patients, and maybe in other ethnic cohorts as well. So if this is a biologically distinct type of cancer, we need to study it separately. We need to a priori stratify clinical trials, or we need to develop separate cohorts. Now that's a lofty goal, because the first major challenge is access to clinical trials. But I think that if we think about a priori designing our scientific approach with that in mind, and that might actually drive our recruitment and accrual strategies as well.
I think we'll get more deep into clinical trials in a few slides, but we're getting some interesting questions, so I'll add some spice to the discussion before Jennifer comments and Elise. So, race is a social construct. What about our underinsured? How do we tackle educational injustice, environmental injustice, wealth disparity? Adding those layers of complexity to how we handle some of these issues.
So I think that I want to highlight 2 points. One point is that I sit on the National Cancer Institute, our comprehensive status side of our fence at our cancer center as well, as a program leader. And the NCI has evolved into including not only a catchment area, but just recently diversity and inclusion. Those are mandatory parts. They've actually gone up the food chain in regards to scoring and so forth. So I think that until things are priorities across the board, it's hard to tackle a problem when you don't have an infrastructure or an ecosystem that supports that. So at least now we're having this larger I think reinforcement of the importance of disparities across the board, like we heard, it's race, it's access, it's financial, it's across the board. The second is we have to own what we do and we don't do well. So when I first started in my mid-20s, I also ran a Komen-supported mobile mammography van where I did risk assessment, and we went to Black and Hispanic churches and organizations all over Kansas City. And the first thing I realized is no one wanted to talk to me about their risk. And I mean, I was somewhat, could get around my Spanish, but it wasn't great. So first off, I had to own that, right? I had to realize I needed to integrate within those communities using promotoras, using trusted Black women in the church, and that's a first step. And then the second thing is we're not always gonna have a provider who looks like the patient sitting in front of us. So the best way I think is for us to say, you know, there are going to be things that are important to you, or I don't have a good understanding of. And it's okay to state your limitations because you're an expert in the science of cancer, but I'm not always an expert in what religious background or ethnic background of a patient. So I think we have to own that up front. And I will tell you, patients respond so well to that. They get it. They're like, okay, thank you for saying that. Or they will actually bond more with you if you just sort of own what you do well and own what you're limited in, and you want to learn from them along that journey. So I would suggest that.
And I want to echo the statements that have been made. My cancer center is an inner city cancer center, and it's a university and a county cancer center. So we have quite a mixed population. Half of our patients are Black. We have very few Asian. And the one thing that I think is a clear-cut hallmark is trust. And we learned early on that we had to go to them. They were not going to come to us. Even though our cancer center is in the middle of a city, we still needed to make that outreach. What hit us about 2 years ago is that half of my patients are Black and half of them are white, but the number of people going on clinical trials only had about 10% were Black. And that's actually pretty high, but that's not great. It should be about half, since that's what my patient population is. And I realized that although I thought I had a good relationship with my patients, and I still think I do, they needed the face, and whether I was going to say it or not. And so what we did, and this is just a very practical thing, is I realized that all of our clinical trials people were white. And so we decided to try to mirror those patients, our patient population, with the people that talked to them, that went over the consent, that actually discussed it with them. And our percentage of Black participation doubled within like 6 months to a year. So is that great? It's a start. But again, I think it mirrors the fact that we have to be cognizant that there are some things we probably can't fix ourselves, but we can provide solutions, whether it's on a micromanagerial level or on a macro-managerial level. I will also say that I am worried about the amount of money that's going to be thrown as like spaghetti against the wall for diversity, inclusion, and equity. We have to have an infrastructure of what we want them to do with it. Because just having a committee and just having, you know, everybody all represented is not going to fix the problem. And I think that we have a very unique opportunity in our country right now because it is pushed up the food chain for NCI and everyone else, but we have to guide them as to what we need to do.
I think this is a very provocative point, you know. There's different levels where we can implement change, and obviously there's, on the individual level, the patient in front of us, you know, talking about navigation, patient education materials, but then there's some of these institutional framework things that Elisa's touching on, you know, looking at our staff thoughtfully, looking at our face to our communities thoughtfully. And as we engage with our communities, you know, there is a difference between outreach versus thoughtful engagement of the communities we hope to serve. And then obviously that has upstream effects in terms of policy and trial design. But, you know, there's a lot of nuance in this. And I know, Sonia, your group has done a lot of innovative work in terms of community engagement. So, you know, as we think about outreach versus true engagement, which has even worked its way into the NCI Comprehensive Cancer Center expectations list and how they provide report cards for institutions. Do you mind touching on this and giving us some examples from your practice?
Yeah, actually we're in the middle of doing a pilot study essentially at Vanderbilt where we're working with our community leaders to really try to increase our I would say, clinical trial accrual of Black patients, but really getting more Black patients to even come through the door at a big academic center sometimes it's a struggle. That's just the reality. A lot of our patients are being treated in the community, and there's a lot of perception around sometimes coming in a big academic center as it pertains to minority patients, Black patients in our national area, and I'm sure in some of the areas that you guys practice as well. So we have really partnered with our community leaders to really try to figure out how we can, and of course we hired a Black patient navigator. So again, because you really have to be intentional. We can't just, I think a lot of times we are guilty of just, we have these lofty ideas, but then when it comes to the practicality, we feel we can just do a one-size-fits-all. But if we're really trying to increase the accrual of Black patients, let's try to get that Black patient navigator. Let's try to have some needs assessment where if a patient is underinsured or uninsured, how can we fill those gaps so that that patient don't not then get on that clinical trial if they're having some issues with maybe getting to the clinic for transportation issues or getting off from work. How can we supplement what's needed in order to kind of remove some of those barriers? So we're really trying to take an upfront approach to look at how can we not only get our patients in the door, but when we're asking, because of course I was going to touch on that issue of not, I guess we can call it bias. So a lot of times what we've seen from prior studies is that not all providers are asking all patients to get on a clinical trial, let's say, at the same rate, right? We have seen that over and over again, because maybe you think, you know what, this patient have more going on, comorbidities, whatever reason, again, some bias. That may be true, but sometimes may not be, right? And we see when Black patients are offered clinical trial, they actually say yes just as or even more than our non-Hispanic white patients. So again, just ask, right? I think ASCO had that initiative where that's the real summary for all of us. Just take away that bias. You have a patient in front of you. We know the importance of a clinical trial. Just ask and see if that patient will say yes or no. And if no, what are some of the barriers and can we work to mitigate some of those barriers?
Neil or Elise, other thoughts?
Yeah, so I'll just add, excuse me, from the going back to the clinical trial design standpoint, I think that we can have all of these efforts to get more patients onto clinical trials, but if the design and the practicality of the trial is not feasible for the communities that we're targeting, it's not going to work. And so as an example, I'll give you an example of one of the things that we're trying, and I don't say this as something that you should do this or try this. I don't know if it'll work, but we'll find out. We are addressing this issue of every time we hear about a disparity, biologically speaking, there's this lingering question of BMI. If you control for BMI, we just heard that if you control for BMI in the RxPonder data, you see the associations get a little weaker. In our own lifestyle data, we find that it's a lot more complex than just BMI or obesity. The biology, again, in the microenvironment, the adipose tumor crosstalk is very different. So we've launched a study. We have a phase 2 trial going on that's testing standard chemotherapy for patients with metastatic triple-negative breast cancer, but we're adding a MET-AP2 inhibitor, which is a drug that has both metabolic and anti-tumor activity for patients who have some kind of metabolic dysfunction, and we're targeting Black patients because that's the group where we feel that if we can intervene with standard of care and a metabolically targeted intervention, perhaps we can improve response. In order to successfully carry out that trial, we need Black patients to enroll. So before we launched the study, it's called the Aretha study, we went out into the community and did multiple focus groups. And we said, what is it going to take for people to participate on this trial and to be interested, motivated, and most importantly, excited to participate on this trial? And we got some amazing feedback. We established some great partners in the community who are helping us accrue to this trial and even design the trial. So I'm hoping that'll translate to successful accrual, but we've just opened, so we'll find out.
That's awesome.
And I think building on what you just heard too, I think that patient engagement is, we talk about it, but it is so hard. And so we need to learn and not sort of think that we know what's best. As part of our catchment area and community efforts, we've had an outreach arm of our cancer center for years, but as part of that, about 10 years ago, we started Pivot, which is patients and investigators together engaging in research. And it's not in name only, because I can't tell you how many times we have like a patient advisory board, but we don't really use them well, or we don't really listen to them, or we don't have the right representatives. They're like the super users, as I like to call them, but they're not the practical user. And so the interesting part about Pivot is they started doing a rapid reactor. And so we have over 80 patients, caregivers, community leaders of all different backgrounds who are part of Pivot. And so I was an early adopter, of course, so I would run my concepts by, I would do everything, and you would not believe how much better your studies get, right? But the other piece of that has spun off to all these interesting people who are on Pivot who have unique backgrounds and unique outreach. So one campaign that we just finished was working with a Hispanic marketing company with several of our Pivot members, and not only did they do a social media campaign targeted in English and in Spanish to Hispanics, but they did murals all over Kansas City that are really cool from graffiti artists. And so all about clinical trials. So these are unique ways that you're working outside the box, but you're not confined to your box because we live in an academic medical center or in a community cancer center. Use those strengths. We do so much in the rural setting. We are a very rural state. I've used telemedicine for over 15 years. So these are things where how do we leverage the strengths that we have, but not reinventing the wheel. So I would say patient engagement with advisory boards that are meaningful, not just a checkbox. Focus groups, all these things are very helpful, but there has to be resources and commitment to making it a useful tool, and it can't just be a nice social worker who you say, oh, go ahead and run our patient advisory group. That's not gonna cut it. It has to become a priority.
I love this, and I think you're bringing up something important about engaging relevant stakeholders and also just kind of being innovative in who we think to be our point person, right? Yes, there's the cancer center, the medical staff, but there are community leaders who are vested in the well-being of their communities who can often be important mouthpieces to help us bridge that message, and maybe can help us more than sometimes folks who are kind of in the ivory tower can necessarily do on their own. So we've done something similar in our community. That's why I'm excited to hear what Jennifer's talking about, where we've engaged with barbershops and Black churches and certain key community leaders to kind of help be mouthpieces for some of our education and screening initiatives in our community. And one of the resources that institutions in the community can use is this notion of this community needs assessment, which basically can help community leaders get a snapshot of their local policy and the current health environment in their community. I have the website reference below, and really this goes a bit more deep than like zip code data per se, and it gives not just cancer outcomes but cardiovascular, maternal fetal outcomes, and allows really community engagers to look at potential areas of intervention, whether it's policy, system change, or environmental change, to see if we can address some of these structural issues that underlie a lot of our health outcomes. NCCN has this reference also in terms of the institutional and practice equity report card, and community engagement is one of the items. It also includes things like accessibility of care, social determinants of health, addressing bias in our care delivery. I love that a number of panelists have touched on, also acknowledging our own biases and limitations, even if we're passionate about this type of work, because sometimes just bringing this part to the discussion, I think, can be so helpful in reframing questions and get some innovation. And then clinical trials. I mean, we've already started touching on this, and it comes up again and again. I don't know, Elise, do you want to start with some of our discussion?
Sure. So there's bias that's not just always racial, and one is age. And since I'm over the age of 60, I'll talk about the age bias in clinical trials. So we know that cancer is most common over the age of 65, but only 30% of trial participants are in that age group. And so it's clear that some of the recommendations we make for our patients that just are older, as well as those that are younger, under the age of 30, for example, may not be quite appropriate. And the reason I brought this up is because both ASCO and the NCI have had very large dedicated workshops in the last year or two, and perhaps some in this room have been part of those, trying to figure out the best way to handle this. And I think one of the most important things is particularly in the aged trial, is that there be an assessment of fitness, not necessarily age. We don't really care if you're 70 or 80, but we do care what your fitness is and your functional status is. And just to piggyback a little bit in the essence of time onto what Neil has said, study design was looked at very much in this monograph you'll see, which was just published about 4 weeks ago now. And it's designed, it tells us that we should have trials that are specifically designed, in this case, for older patients. They should include a parallel cohort of older patients and also stratified randomization. And there should, within the trial, be embedded a cohort of older patients. So again, we shouldn't just see what happens. We should actually have a dedicated look. Same thing with Black patients. And the other thing, we need to be pragmatic. You know, it should be something that's achievable. We shouldn't make it so lofty that you're not going to be able to get that specific patient group represented. And having pragmatic design elements will be also very important. And I think I'll turn it back to you with that.
Yeah, other thoughts on the panel about clinical trials? Jennifer, Neil?
I think the only thing I would say is I grew up in an environment where it was like throw the kitchen sink at it and like see what sticks. That is so not what we need to do now. And I loved your word pragmatic, because we have to be practical. We have to design trials that we can do much more efficiently. I mean, I want to start us to start building smart trials, right? Where we do things better, we're informed by real world data. We really can make trials smarter, and there's some great steps to that. So that would be my dream.
You know,
What did you say, pie in the sky? So yes.
I heard yesterday that someone said it would be 10 years before we got data from a clinical trial, and that was like a stab in the heart. By the time that data comes out, it will be irrelevant.
Yeah.
And, you know, we need to make sure we design studies that we can answer and have a solution to go forward. We cannot use those as building blocks if they become irrelevant by the time the data is out. So.
Yeah, I would just add that, you know, when I think about, when we're designing clinical trials, I think a lot about what you said with regard to confounders. How can we eliminate confounders? And so in our lifestyle trials, I use that as an example. I think about it as implementation versus a biologically driven question. And so in our implementation trials, we are trying to address the social determinants, going out into the community, having community partners. We're doing the same in our trials that are have more biologically driven endpoints, but there we try to eliminate the confounders. So in those lifestyle trials, we deliver the treadmill to the patient's home. We deliver the food to their home, because we're asking very specific questions. If a person follows this exercise prescription, or if this person follows this particular type of diet, what is the microenvironment outcome? Well, if you have a lot of social determinants or other factors, environmental factors that are introducing confounders, really the only way to get to that scientific answer is by eliminating those confounders. Whereas in the implementation setting, we recognize we can't send everybody a treadmill, we can't send everybody their pre-prepared meals. But once we derive the scientific answer, the hope is we can then modify it in an implementable way. So I think that's just another way of saying what you've said, and trying to do that by really thinking about, and also what you've said, by really thinking about clinical trial design in both a pragmatic way, but also the scientific approach.
And I just want to make one point, kind of piggybacking on what Elise said earlier. The time it takes to get results from clinical trial clearly is a problem, but it needs to happen. And I think that's one of the benefits of enrolling patients, especially diverse patients on clinical trial, giving them access to novel therapies, right? And if we're not offering these patients clinical trial, we're not enrolling them in clinical trials, we're literally not giving them access to some novel therapies that they may not be around to benefit from by the time those trials read out in 10 years before that FDA approval becomes available. So I think it even brings home the point why we need to get this done, because we're essentially contributing, if anything, to worse outcomes.
I think we've touched on most of these issues on the summary slide. So with our last few minutes, you know, let's think of policy kind of at a more bird's eye view level, and what have been the responses to some of these issues discussed within the cancer community. So ASCO released the 2020 policy statement on cancer disparities and health equity, and they were really direct in their condemnation of the treatment of communities of color, and really called upon members of ASCO to confront and address these complex forces that have created disparities in cancer prevention, diagnosis, treatment, and research. And then similarly, ASTRO, our radiation oncology professional organization, also had a call to action. And really, they were very direct in stating that we must place racism at the front and center in order to legitimately begin to work with reducing the primary risk factor of poor health outcomes, specifically among blacks in the US. And they actually were very direct in naming racism as a root of a lot of health inequity and also disparate outcomes. So this is just a thoughtful paper written by some mentors and colleagues who've been at the forefront of addressing racial injustice. They're all radiation oncologists, and address not just some of the limitations and issues that come up when we're interacting with the patient in our room, but also issues with workforce diversity, retention, career mentorship, at the faculty level, both in our academic institutions and community practices, and how that also can impact things like who has the power to help have a voice in designing clinical trials and making thoughtful policies in our institutions. So I think we've touched on these in various anecdotes shared by my great panelists, but summary of some of the solutions, as we think at the individual level, that patient who's right in front of us, whether it's translation, harnessing our social networks, even at the institutional level, thinking of things like mentorship and recruitment and also retention of diverse faculty. Obviously, our community needs not just needs assessments, but also outreach and thoughtful engagement with the key stakeholders, and of course, clinical trials, which we've come up again and again. And then policy, we all can have a voice in that and kind of be part of change in our different institutions. So with that, thank you, I guess, for joining us for the panel and for the meeting. And we have some MOC questions at the end.
Any questions from the audience? Okay, well, thank you.